Okay, so hello everyone. My name is Tace Ramize, and my presentation today is on psychosocial factors impacting resource stewardship. So before we get into everything, just kind of a quick overview of some of the major questions that we'll focus on. So first, what is resource stewardship and why should we care? So we'll talk about this just very briefly so that we're all on the same page before we dig into the bulk of the presentation, which will be on what psychosocial factors impact resource stewardship. And then we'll finish with a brief discussion of who needs to do what. And then we'll have some time for questions, comments, or anything anyone wants to discuss. So resource stewardship is the appropriate and responsible use of resources to achieve high value and effective care. And when we talk about resources, we're talking about tests, treatments, procedures, prescriptions, sort of everything that falls under the care umbrella. So why do we care about this and why is it important? Data from Choosing Wisely Canada estimates that up to 30% of tests, treatments, and procedures may actually be unnecessary. So we're not doing so well when it comes to that appropriate and responsible use. And this has numerous implications. There's two big ones. One of the first ones is patient care. So for example, if a patient is undergoing a procedure that might be unnecessary, there can be potential risks to the patient. There's also risk to other patients. So like if we're talking about lab testing, if 30% of the tests being ordered are unnecessary, there's a higher volume going into the system. So patients who really need the test could be waiting longer for results and therefore clinical intervention. So it can have, a direct implication for the patient and indirect implications for other patients in the healthcare system. And another big one, money, the financial implications of it. So, and it can sound a little bit insensitive, of course, because you don't want to look at people as dollar signs, but people should get the care that they need. But the key word there is need. So if these 30% of tests, treatments, and procedures that aren't needed weren't ordered, then there's more financial resources to redistribute elsewhere in the system where they might be needed more. So when we look at a number like this 30% of tests, treatments, and procedures, it seems like a big number. So I wonder if people are surprised by this. My guess would be no, and that we have no shocked Pikachus listening. And that's because sort of in healthcare, everybody knows that this is a problem. Like this isn't really a secret. And in fact, one survey that was done, 73% of physicians said that unnecessary tests and procedures are a serious problem. However, in the same survey, 72% of physicians reported that most physicians order or prescribe something unnecessary at least once a week. So there's a bit of a disconnect here because we have almost the exact same proportion of people saying, yes, this is a big problem, but yes, we do it anyway, and we do it regularly. So what is going on here? Because if we know that this is an issue, why do so many people keep doing it? And it's because when we look at something like overuse and misuse, and we're looking at that 30%, we're looking at this outcome, right? We're looking at the tip of the iceberg. But 30%, this is made up of a ton of little ones, a ton of little individual contexts and situations that lead us to that. And so if we want to do something about this overuse and misuse, we sort of have to dig a bit deeper and understand what's going on and look below the surface to see what is driving or underlying this overuse and misuse. And so that's what we're going to focus on today, the stuff that is below the surface, the stuff that is driving these problems that we see, where we end up with these big numbers, like 30% of tests being unnecessary. So for the psychosocial factors, before we get into these, just a couple of caveats. This is not going to be an exhaustive list. There's a ton of others we could talk about, but due to time constraints, I'm just going to talk about some of the big ones that are most relevant to, clinical situations common throughout the SHA. And the other thing is, although I'm going to talk about most of these separately, they do overlap. So they overlap both conceptually and also in their impact. So in any given situation, there can be a ton of these different factors at play. And they can also have compounding and interacting effects. So it sort of becomes this sort of tangled web of all this stuff that's going on, but just for clarity's sake, I will talk about each of them separately. So when we talk about social factors, so these are things in the social environment, people and groups who influence us. Psychological factors are internal processes that are related to the situation. Personality factors are trait-level stable processes that influence behavior and determine behavior. And environmental factors are things in the external environment or elements of a specific situation that can impact outcomes and decision-making. So we'll talk about each one of these sort of broad categories separately and some examples of them. So with social factors, the first one here is social norms. So this is what other people are doing around us. Sort of everybody starts to sort of do the same thing when in groups. There sort of develops a status quo or collective norm. So if you happen to be in a department that, is quite conservative, say with prescribing or ordering tests, you're more likely to adopt that in your practice as well. Similarly, if people tend to order a test for everything, you're more likely to sort of lean that way as well. Even if you're not initially, it sort of happens over time. And then we have social or team dynamics. So sort of the structure of the team and the group and how you communicate and interact with one another. Some teams are, very, very open to discussing things like stewardship or how they handle cases. Some departments will get together once a week or so and discuss different cases, how they handle things, what other people could have done, giving each other feedback. And some departments are, very closed off to that. And giving feedback to another clinician is seen as criticizing them. It's seen as a no-no and kind of overstepping bounds. So those dynamics within a team influence how open those conversations are and how people can either grow together or not. And then there's modeling. So this is particularly important in residency or early stages of one's career. So this is how the people training you or teaching you do things, because you learn this way as sort of the first exposure of how to do things. And it sort of becomes these cognitively entrenched habits that you revert back to in daily practice. And then the last one here, and this is a big one, so benevolence and altruism, particularly towards patients. So wanting to do the best thing for the patient and make them feel okay. So in one study, 47% of physicians said that patients request an unnecessary test or procedure at least once a week. And, with there being Google, WebMD, all those kinds of things, people are diagnosing themselves. They're afraid that they have every condition under the sun, and so they want to be tested for it, or they want a prescription for it. And a physician might know that medically it's not necessary, but it can be very hard when you have someone in front of you asking for something. They're clearly distressed, they're upset, they're feeling anxious. So you might go ahead and order a test even if it's not needed, just to give them peace of mind, because you want them to feel okay, even though it's not medically necessary. And our next category here is psychological factors. So the first one here is fear of reputational risk. So both with patients, sometimes people aren't always reasonable. If they don't like the answers or responses that they're getting, you know, you might get bad Google or Yelp reviews. And with colleagues, there might be a desire to satisfy referral requests to keep a good reputation with your colleagues. And then there's fear of complaints or legal concerns. So in one survey, 52% of physicians said that a major reason why they order unnecessary tests is concern over malpractice issues. And even if there's not a potential situation for a legal concern, just a complaint, right? If a patient doesn't like the way something goes or something goes wrong, you know, even if it couldn't have been expected, even if just a complaint goes in, then, you know, even if it's unsubstantiated, there has to be certain meetings. There's red tape to go through. There's bureaucracy to deal with, just to get to the point where it's said, okay, it's unsubstantiated. And most clinicians have better things to do than go through with that. So if they feel like this sort of situation, that could be a potential, they might be more likely to write a prescription, order a test, whatever it is. And then we have fear of adverse outcomes. So as with the above, it's the fear of some sort of negative situation, but this is more a negative situation with something happening to the patient. Even if something is unlikely, wanting to keep your patient safe and not have something happen can lead to a sort of defensive medicine strategy. And that can happen particularly in situations where there's a lot of uncertainty or there's a lot of unknowns. It's unclear what's going on. And people who have a low tolerance to uncertainty or low ambiguity tolerance may be more likely to then use that defensive medicine strategy. In fact, one study found that 30% of physicians said that a major reason why they order unnecessary tests is just to be safe. So there's no medical reason to order the test. They're doing it just to cover their bases, just in case. And the last one here is perceived competence. So this is different from actual competence. This is the confidence that one has in one's ability, regardless of what those actual abilities are. And this can particularly come into play in early stages of one's career, but of course it can be throughout too. So one study was looking at residents in surgery and found that 27.5% of surgery residents worried that they wouldn't feel comfortable and confident performing procedures independently. Additionally, 63.6% of the surgery residents said that they worried about hurting their patients. So it is good to worry about your patients, but we can kind of intuitively understand how a fear of hurting one's patients combined with a lack of confidence in one's ability to perform procedures independently can lead to this just to be safe or cover your bases or defensive medicine strategy, even if something isn't really needed. And then we have personality factors. So the first one here is attitudes towards guidelines, authorities, recommendations. So this is sort of at a general level what someone's attitudes towards these kind of things are. Do they view them as helpful? Do they view them as too restrictive and not really allowing for variation in patient cases? And sort of at a base level, people differ in their attitudes towards these things. One study looked at physicians and how they make medical decisions. So the study gave physicians a bunch of different factors and asked them how important these factors were when they made complex medical decisions. And one of the factors they asked about was guidelines and how much weight should they carry when you make a complex medical decision. And physicians varied in how important they thought guidelines were. So 59% felt they should have a lot of weight, 18% felt they should have the highest possible weight, and 23% of physicians felt that they should have just some or little weight. So we can see people just sort of differ in their general attitudes to how important these things are. And the next one here is a sense of autonomy. So here we're talking about practice autonomy. So how important it is to people to sort of have their own judgment and impose their own judgment on the situation. So in the same study as above, physicians were asked how much their own judgment of what is best for the patient, how much weight that should carry when making a complex medical decision. 15% felt that it should be the highest weighted factor. 59% felt that it should carry a lot of weight, and 25% felt that it should carry just some weight. So again, we see across the board, people just kind of differ in how important they think their own autonomy and judgment and opinion is. And then we have dispositional motivational tendencies. So how sort of the predisposition towards thinking in certain ways. So particularly with approach and avoidance motivation, or how driven people are at a neurobiological level by the behavioral inhibition system or behavioral activation system. Individuals who are higher in avoidance motivation will focus more on avoiding negative outcomes. So clinicians who are predisposed to this kind of motivational tendency will be more likely to overtreat and overuse and have that just to be safe mentality. And the last one here is communication abilities. So people differ in their ability to communicate and in their communication styles. And we hear about sort of jokes about, you know, some physicians having poor bedside manner and stuff. And it's true that some physicians just aren't really great communicating with patients, and some are. People just vary at sort of a baseline level with how well they do with this. And this can come into play when they're trying to explain to a patient different options or why something is necessary or why it isn't. The way someone communicates will determine sort of how the situation goes. And then we're into environmental factors. So the first one here is communication outcomes. So this is sort of piggybacking off of the communication abilities we talked about, except this is sort of about how the actual conversation goes. So you could be the best communicator in the world, but maybe you're dealing with someone who isn't a good communicator. Maybe the patient is a poor communicator, whether it be by nature or due to the situation, because they're in a situation that is, you know, very upsetting and stressful to them. Sort of depending on how those communication styles match up and how the communication goes. One study found that 53% of physicians said that if a patient continued to be insistent, they would just go ahead and order a test. So this kind of shows, you know, no matter how good someone is at communicating, if the patient continues to be insistent and keeps going and the conversation just sort of goes sideways, just over half of physicians are indicating they'll just kind of throw up their hands and say, okay, we'll just order it. And then we have pressure and timing. So situations can be constrained either because a decision has to be made immediately based on a patient's condition, or perhaps it's just the pressure a clinician is under and they have a ton of other patients that they're waiting to see. And in a situation that is high pressure, somebody might not have time to really think things through in the way that they should. They might not have time to go and check guidelines. They might not have time to go and discuss things with colleagues and get another opinion on how to handle things. And so in those times, people tend to sort of revert back to those cognitively entrenched habits that we talked about earlier. So that's why it sort of becomes important for guidelines and recommendations to really be memorized, and so that they're sort of taken as a rule of thumb so that we don't revert back to the kind of defensive medicine strategies in times where it's high pressure. And then we have prior experience. And here we're talking in particular about prior negative experience. So if something bad has happened before, let's say, even though there was no indication something could happen, something happened to a patient and they either had an adverse outcome or they passed away or some sort of negative thing happened with that patient, even though there wasn't a reason to expect it. And this is where the negativity bias comes into play, because negative things grab our attention more. They affect us more. They're more readily remembered in the future, and they have longer lasting effects than positive experiences. So even if something very unlikely happened just one time, it seems more salient because it happened once. So the odds of that event haven't actually changed, but it seems more likely to happen. So in the future, people can adopt that just to be safe mentality to avoid that happening again. And then we have level of experience or stage of career. So earlier on in one's career, maybe people have lower perceived competence, like we talked about before. So they might be more likely to use broader spectrum therapies, whereas later on in one's career, one had more experience. They might be willing to accept more immediate risk. This can affect communication abilities and the benevolence and altruism as well. Maybe earlier on in one's career, people still have the rose-colored glasses on. They care more what the patient thinks and wanting to please them. People might care less as they start to get later in their career, and they just want to do what's best, even if it doesn't necessarily make others happy. And the last one we have here is burnout. And this one is, in my opinion, probably the most important one because it also impacts all of the others. So the level of burnout that one is experiencing at a given time will impact their practice. So if somebody is, at a given time experiencing high levels of burnout, they might be too exhausted to really have a drawn out long conversation with a patient about options. They might be too exhausted to go and check guidelines or go and discuss with a colleague. And these are all things that are important for resource stewardship and good, but this is sort of in an ideal world, right? And it's like asking someone whose tank is on empty to go the extra mile. Like, it's just not going to happen. And all of these things that are really important for resource stewardship depend on people working in certain conditions. And right now, healthcare workers oftentimes work under conditions that are so far from ideal. So there's really a disconnect in what people are asked to give and what they have the ability to give at any given time. And so one recent study found that 62% of physician residents met the threshold for burnout. And that was before COVID. The study was done just before COVID, so the numbers are likely even higher now. And that study is not just a one-off. Sort of across North America, these are similar numbers in every single study. There are very high levels of burnout for healthcare workers. And so now that we've talked about all of these different factors that can impact situations, so what do we do with them? And who needs to do what? So we've talked a lot about things sort of from the physician's perspective and all the things that could be impacting that situation. But the truth is, there are so many different groups that have a stake in resource stewardship. There are governments who are funding healthcare, hospitals who want their facilities to function well. There are departments like ours who have, a heavy interest in stewardship. And then physicians themselves who want to do well in their practice and want to do what's best for patients. And the general public who want to receive good health care for themselves and others. So it's a good thing that there are so many people that have a stake in the game, but it can also be an issue because what starts to happen is a bit of a diffusion of responsibility, where when everyone is responsible, no one is responsible, because the accountability is sort of dispersed amongst so many groups. And this is a little bit dramatic because, you know, people aren't usually doing physical finger pointing, and most people don't even realize that they're doing it. But we see it oftentimes, even looking at these results. You know, physicians are saying a lot in some of the studies I've talked about, well, patients are asking for this. Or they're saying things like, well, the hospitals don't have clear enough guidelines, so other physicians are doing it, so I have to do it too. You know, and the government is looking to hospitals to then have, you know, better guidelines, and it sort of becomes a mess. So it's important to sort of be cognizant of this and know that instead of looking at every other group to do something about it first, we can each sort of be individually accountable. Whatever role you are in this, whatever role you have in the healthcare system, there are things that everybody can do in order to try and improve the situation. So what are those things that we can do? Making sure that we're questioning things. So say if you're a patient, questioning your physician on what all the options are, why you are getting a certain test, what's it for, what is it going to tell us? If you're a clinician, asking yourself, is a test really necessary? What clinical value is it going to add? Is it going to change the diagnosis? And really considering that. Communicating. So if you are a patient, let's say, communicating with your physician, what your concerns are, what your questions are, what you need from your physician. If you are a physician, communicating with your patient and making sure that they know all of the options, they know why something is being done, they know what the different options are. And before we go on from this, just to highlight how important this is, because I feel like most of the time physicians see something like this and think, yep, I do that. I am a great communicator. I tell people things every single time. And most people are not actually as good at this as they think they are. So, and this is because it's not about just going through the motions and sort of ticking boxes, like, yep, I gave this information, yep, I gave this information. There was a study that looked at this, and it was really interesting because they had both patients and their physicians fill out the same questionnaire. So the questionnaire asked patients about their health conditions. So what the different options were for their treatment, what the benefits of different treatments were, sort of what the expected outcomes were, all those kinds of things. So the patients answered these questionnaires with their understanding of things. And then they asked the patient's physician to complete the same questionnaire with how they thought their patients answered. And the physicians felt super confident doing this because they felt like, okay, I've communicated with my patient, I've told them all this stuff, I know that they know this stuff, yep, okay, this is how they would answer it. And the results indicated that in all 6 domains they looked at, the responses were significantly different. So in every single aspect, the physicians got it wrong. And these are physicians who had sat and felt like they had communicated with their patients. So it's important to understand that when we're talking about communication, it's not just at the surface level. It's not paying something lip service, checking off boxes, saying, yep, here's the information, or throwing a brochure at someone. It's about the actual quality of the conversations that are being had. And the last one here is reflect. So this is important for everybody to do as well. So let's say, for example, people within our department, when we're looking at things like clinician reports, we often look at the outcomes, the numbers, and see who's doing good and who's doing bad. But are we really reflecting and, working with the physicians and reflecting on why we're seeing the numbers that we are? And for physicians, reflecting on different situations that you're in, thinking about the different psychosocial factors that might have played a role, thinking about why you ordered tests or why you sort of went with one course of treatment over the other, what the outcomes were, what you could have done differently. So no matter what role anybody has in the healthcare system, focusing on questioning, communicating, and reflecting, and putting these sort of underlying psychosocial factors and considering them is important to do, and sort of helping us to get below the surface so that we can potentially make some real differences with these things. And so that is the end of my presentation. So we have some time now if people have questions or